Hello, my name is Aijaz Sofi and I am gastroenterology fellow at University of Toledo Medical Center. First of all, I would like to thank the editorial office of GI Endoscopy Journal for giving us opportunity to present the findings of our study entitled Simultaneous Endoscopic and Laparoscopic Approach in Patients with Acute Iatrogenic Bile Duct Obstruction. Before discussing the paper, I would like to provide a brief background about the topic. Bile duct injury is a well-known complication of cholecystectomy, and its incidence ranges from 0.4 to 0.6% in laparoscopic cholecystectomy and 0.1 to 0.2% in open cholecystectomy. Such injuries are associated with significant perioperative morbidity and mortality and reduced long-term survival. In addition, the quality of life in these patients is significantly affected. Bile duct injuries from cholecystectomy could range from bile leaks to occlusion of bile duct from surgical clips or sutures, or complete transection of bile duct. In this study, we'll be discussing the novel method of management of patients who present with occlusion of bile duct from surgical clip or suture ligatures. Such injuries are usually identified in the post-operative period by performing ERCPs. The standard approach in these patients involves an attempt by an endoscopist to place a bile stent across the stricture. And if the endoscopist is able to place a bile stent, then these patients require multiple ERCPs aimed at gradual dilatation of the stricture. However, if during initial ERCP, endoscopist is unable to place a bile stent, then these patients would require open surgical methods of creating a new bilioenteric channel. Usually it is Roux-en-Y choledochogenostomy. In our study, we present a novel method of concurrent endoscopic and laparoscopic approach in patients with acute iatrogenic bile duct obstruction. In this method, we perform ERCP, obtain cholangiographic images, and to delineate the site of obstruction of bile duct. Then the surgeon approaches at the same time to the obstructed bile duct laparoscopically, and then under continuous cholangiographic imaging, the surgeon removes the bile duct clips or sutures from the duct, and following the removal of the cause of occlusion, we obtain the complete cholangiographic images to delineate the biliary anatomy following the removal of the duct, following the removal of the block. Then the endoscopist places a bile stent because the bile duct is very leaky from the surgical clips or sutures. Now, it is very important to emphasize here that the surgeon should approach the site of blocked bile duct by suction irrigation technique, and there should be no sharp dissection during the procedure. We attempted this procedure in 3 consecutive patients who presented with acute iatrogenic bile duct obstruction very early in the post-operative period. In our case, within a week of procedure. In 2 of these patients, endoscopist was unable to place a bile stent, and in 3rd patient, endoscopist placed 5 French stent only with significant difficulty. All the 3 patients underwent the combined endoscopic laparoscopic method, and the cause of occlusion was completely relieved in all the 3 patients. During the follow-up, at the time of removal of bile stent 4 to 6 weeks later, the cholangiographic images showed complete resolution of obstruction in the bile duct, and the biliary anatomy was completely normal. These patients were followed up over the range of 20 to 30 months, and during this time period they were asymptomatic and their elective state normal. Therefore, by using this technique, we obviated the need for surgical procedures like Roux-en-Y choledochogenostomy, which is usually indicated in these patients. In addition, the technique is more attractive and cost effective than the standard conservative approach of management